Hi everyone, welcome back from the tea break. Thank you again for coming today. We're very glad to have such a great group here and to have such old friends and old colleagues who are happy to see each other again, as well as new faces. I think we've had a lot of lively discussion already, and we're looking forward to it continuing for the rest of the day. Our second panel of the day is going to focus on autonomy and meaning in death. And our theme for the day generally is supporting patient autonomy in old age and death. So we're not just talking about death today, we're talking about old age as well. So it won't all be death. And when we talk about autonomy, we're also going to add some complexity to that idea. And I think that will come out in this session. I know Terry, at least, will add his own sort of spin to the idea of autonomy, because we want to think about autonomy as, of course, a good thing that we encourage and support, but we can also think about how it can be complex, how it can change depending on the situation and the context. We think about the autonomy of the patient, but we think about the patient's relationship to the family, to the doctor, and to society. So I think we'll have some really interesting talks in this session. Our speakers are our two co-directors of the Center for Medical Ethics and Law, Terry Kahn and Philip Bay. And we also have Janja. Sorry, I've never said your last name out loud. I apologize for that. Who's from the Medical Ethics and Humanities Unit. So first of all, we will have Dr. Philip Bay, and I will introduce him now and then do the others as they come up. Philip is Associate Professor in the Department of Pathology of the Lee Cushing Faculty of Medicine. He's been a forensic pathologist since 1982, 1 year longer than I have been alive. In his work, he regularly meets with family members of individuals whose deaths are reportable to the coroner, which is something we've heard a lot about in the morning. So you're finally going to get the details of why we have to do this in Hong Kong, why we have to do this ridiculous thing. Ask Philip, he's going to tell you all about it. And this happens, of course, when issues such as the need for autopsy arises and when funeral preferences are finalized. So without further ado, Philip.
Thank you. Good morning, everyone. It's great to see you all here. Some of the things I'm going to say really flows from some comments made earlier by our three speakers this morning. And I hope by the end of the next 15, 20 minutes or so, you will realize that there are some, I suppose, myths or misunderstandings with regards to the realities of dying at home in particular. Okay? But very quickly, let me just take you through some of the basics that we have in Hong Kong. This is roughly what it is like in Hong Kong, the number of deaths we have each year. So we are an aging society. More and more people are dying. Back from 89, it was about 27,000, 28,000 deaths a year. It's now 42,000, 43,000 a year. And it is a gradual and I suspect continual rise. Okay. Some of the other information there is to do with reporting to the coroner. In 1997, we had a slight change to the coroner's ordinance. For those of you not familiar, the coroner's ordinance in Hong Kong pretty much mirrored what was going on in the UK. So the whole point of it was all sudden, unexpected, unnatural deaths has to be investigated. Okay, in Hong Kong in 1997, we put in an implementation that introduced, at that time, the idea that we would define these situations a little bit better. The whole background of that was there was a suspicion that doctors were not reporting cases to the coroner by misinterpreting what was unnatural or sudden, etc. Okay? However, if you look at the data, it actually has not resulted in any increase in reporting to the coroner. So roughly about 23% of all deaths in Hong Kong are reported to a coroner. Okay. What has, however, happened is the percentage of those cases that are investigated or are autopsied has dropped. Okay, there are a variety of reasons for that. We could argue, depending on where we stand on autopsies, whether it's a good thing or a bad thing, but that's not really what I want to talk about today. So of this number of deaths, where is it all happening, or what is happening? Now, we all again have heard that most deaths are in hospital, okay, which from our daily experience is probably true, but how many deaths are actually in hospital? Now, if any of you are involved in research, you know that Hong Kong is such a frustrating place. We do actually have a lot of information and data generated by a lot of public bodies and organizations. It's just they're not friendly, and they seem to have a knack of making life difficult for you. Okay, so trying to find out how many people die in hospitals in Hong Kong, I finally managed to get it in the Hong Kong, or in the Hospital Authority annual report. Okay, but if you look at it, the annual report of Hospital Authority follows the financial year, so they always have 09, 010, 010, 011, etc. You look at the Department of Health annual reports, they are yearly reports. You look at coroner's reports, they're yearly reports. So you obviously have some mismatch in the numbers. But taking that as the background and getting, allowing for some slippage and differences, roughly you can see that in hospitals, 30-odd thousand deaths a year. Okay, so almost 75%, possibly coming up to 80% of deaths in hospital. All right. Private institutions includes private hospitals. It includes maternity homes and some of the so-called gazetted care homes. Not all care homes. Okay, there are private care homes. Why do I include the forensic pathology service? Because technically, any deaths where it's not in hospital, where there are no doctors certifying the death, as we heard earlier, there's a move, or the trend is that the body is sent to, let me repeat. Family would generally call 999, the ambulance arrives, the body is moved off to an A&E department, which then certifies death, the fact of death, and then the body is sent to the public mortuaries, okay, which is under the control of forensic pathology services. And if you look at reportable deaths, that is deaths reported to the coroner, it's more than what the forensic pathology services are getting. So where are they going? And here is where the pathology departments in some of the major HA hospitals come in. Okay, that's where some of the coroner's cases are being seen. So perhaps as a reply to why a death in hospital ends up in the morgue, it depends on whether that case was reported to the coroner for whatever reasons. The autopsy rate now is dropping and dropping, and currently is less than 40%. So, if I'm being negative, I would say that we're wasting 60% of our time, okay, in reporting cases to a coroner where nothing is done. So why are we reporting it to a coroner? Why would, okay, people who die in hospital, generally, if your doctors are happy and know that you died from a natural cause of death, they can issue you with a certificate that states your cause of death, okay? That's the start of the paperwork. Family members collect this, takes it to the registrar of death, and gets an official death certificate. Now, that official death certificate allows for all the funeral arrangements that comes along. It allows for also the moving of that body from the hospital to the funeral home, etc., etc. Okay. So that's the easiest, I suppose, or the most convenient in a sense. However, if you need to report to a coroner, then things get difficult. The number of unnatural deaths, if we look at the coroner's annual reports, is actually not huge, okay? It's only a small percentage of the reported cases, so maybe about 30% or so of the cases reported to the coroner are actually the unnatural deaths, the accidents, the suicides, homicides, or even occupational related deaths. The 20 situations that we put in 1997 for reporting, obviously if no one knows the cause of death, it needs to be reported, but there are a lot of technical ones in there. Deaths due to custody, deaths following surgery, following anesthesia, and one of the issues that has constantly been brought up is death in homes or in care homes. But if you look at a further sort of elucidation of that, it is actually death in care homes where it's for profit. Okay, so deaths in gazetted homes, homes run by the hospital authority, actually doesn't really come into this, but it's never really been made clear, so there's often a lot of misunderstanding there on those issues. There's also a problem sometimes that we see with doctors in that they continue on the old trend of definition of sudden death, which is, oh, the patient has not been in hospital for more than 24 hours, so we have to report, which is not true. I mean, modern technologies allow diagnosis to be made so quickly now. I mean, acute myocardial infarction with troponin tests can be diagnosed, or with ECG can be diagnosed within minutes. You don't need 24 hours to get a diagnosis of that. Okay, so we have those issues sometimes that lead to what I would call, from my perspective as a forensic doctor, of an over-reporting of cases to a coroner. So those are some of the issues. So basically, the unattended deaths, okay, is a third one, and this one is the bit that's challenging for deaths in elderly home as well as deaths in the home, okay? Because there is a clause that demands that whoever is signing that death certificate needs to have seen that patient at least within the last 14 days of their illness, okay? So you should at least have a doctor see a family member who is maybe terminal every 2 weeks or so. There is also a further clause in a different ordinance that requires the doctor who's signing that death certificate to actually see the body. Okay, so those are some of the two prerequisites that may be needed if we want to look at deaths at home. Okay, so with the private care home, I think there's a need to define it properly and for us to be clear what are the private care homes that needs to be reported and which are the ones that don't need to. Let's ignore that, because what we're seeing with the numbers as we have it publicly is that there's a lot of overlap. We're not clear how many people actually call for help when they died at home. Okay. Generally, if you talk to people in the industry or doctors, the impression is very few people die at home, okay, because they all end up in the public mortuary, and there's a lot of issues with police statements, police reports, etc., etc. If you look at the ordinance, there's nothing that really prohibits you. Okay, so you do need a doctor to sign a death cert, or more correctly, a cert containing a cause of death. So that's needed. The doctor cannot sign and say, I don't know, cause of death unknown. That's not really acceptable. Okay, so you need that. That doctor also needs to view the body. So for anyone thinking of or planning for a death at home, you need a very friendly doctor, a doctor who knows the patient well. And here lies one of the problems Hong Kong face. We've talked about family practice or a family GP system for at least 20 years, possibly even longer than that, and we're not getting anywhere near. And unless we have that, there's no relationships with patients that stretch for a long period of time, that doctors are perhaps more willing or prepared to actually visit patients at home. Currently, this is a rarity, okay? So that's something we need to overcome, but I would put to you, it's not impossible, all right? Other bits of ordinance, once you have that certificate, actually everything is easy, okay? You can then register the death. Registration of the death allows for all the other things that needs to happen. And effectively, you don't need to do that yourself. Currently, all of those things are done by the funeral people who are helping you with the funeral arrangements anyway, okay? So it's a matter of being able to get the documentation. Problem arise in dying at home because the usual system of things are all happening in the hospitals, okay? I would venture to say that police officers, funeral people, doctors are all unfamiliar with this situation of someone dying at home who's not being reported to the coroner, who then goes straight to the funeral home and has the funeral arrangements organized. So we need to work on informing people involved that one, this is legal, and two, this is doable, and three, there's nothing wrong or suspicious about that. But we need to put all of these things in place. To start with, we have this really old ordinance, but it actually says that you cannot keep a body in a place where there are people living for more than 48 hours, okay? So that's a time limitation on what you can do when someone dies at home. Things do need to move reasonably quickly, but not impossibly quickly, okay? And then in case people get a little bit slow, there's another clause in it that says that even if you have the body in a sealed coffin, you cannot keep it there for more than 7 days. Okay, but that really doesn't affect us that much. In Hong Kong these days, everything is done in funeral homes anyway, so there are no wakes or funeral services that are conducted at home as in other parts of East Asia. I mean, in those of you who have traveled to Malaysia, to Taiwan would know that often funerals are actually conducted in the driveway of private homes, okay? And bodies could easily be there for 5 days, 7 days, in some 11 days for very elaborate ceremonies. So what do you actually have to do if there's a death at home? If everything goes to plan, you need a doctor to attend, to view the body, and to issue a cause of death. With that document, it then needs to be brought to the registrar of death, where the death then is registered. The registrar would then instantly issue to you the official death certificate, with which you can then authorize or show to your funeral directors who can come and collect the body and move the body to funeral homes. Okay, so it's very doable, provided you can get this to them during working hours. Okay, so as we all know, government departments work 5-day weeks, some work Saturday mornings, but in case they are not working, what can you do? Do you keep the body at home for 48 hours? You actually don't have to. Under the Birth and Death Registration Ordinance, there's another section that actually allows you to go to the nearest police station and request that the police officer or the inspector in charge at the police station issue you a Form 8. A Form 8 is permission to move the body prior to the body actually being registered with the Registrar of Death. Now, I know from personal experience that it happens, but it doesn't happen frequently. And this is perhaps something we need to develop if we want to promote death at home. So we need to really talk to police and say we're going to start pushing and invoking this, okay? Obviously, the police officer who's going to issue that may say, okay, we want to see the death certificate, we may want to make sure that there's no suspicion, but I think that's fair. That's not a problem, that's not a hindrance to things happening, okay? So that can actually happen. And with that Form 8, the body can be moved to the funeral home. Okay, so you don't have to keep the body at home for, until the death registry opens. And in that format, so you just have that interim bit where you need to go to the police station and get that Form 8. Okay, you still eventually have to register the death, but as you can see, things can happen, okay? So hopefully I've demonstrated to you that it is possible to die at home. It is legal to die at home. It is doable to not have to go to A&E, not have to involve the coroners, etc., etc. But really we need to get in place a few things. So why are there so few dying at home? I think most of the problem lies in most of us are totally unaware of these little bits of ordinance that you can use. Most people don't have a doctor that is willing to come to the home and certainly come to the home to issue a death cert. And certainly, it's not easy. Well, people are not used to it. Okay, most people, when anything happens, just dial 999, and once you do that, everyone appears. The police, the ambulance, but that then involves instantly the hospitals and the A&E. Okay. Consequence of all that is that, in some sense, we're wasting the use of ambulance, we're wasting the use of the A&E, we're actually wasting a lot of the coroner's time, so the police, the pathologists, the court, and all of that, if you put it, or if you look at it in terms of resources, it's a waste of resources. If we can channel this to what was earlier described as a good death at home, in the comfort of your loved ones, wouldn't it be so much more better? And it's certainly worth doing. Okay, there are all these other issues, but I won't go into that. I'm running out of time now, I think. Issues with more trees, etc., etc. But we'll leave that for another time. But my message perhaps today is it is doable and it can be done. All it needs is a group of people willing to perhaps start pushing for it. Okay, thank you.
Okay, so now you know how to die. Next we have Terry Kahn, who is also co-director of the Center for Medical Ethics and Law. Terry is Associate Professor of Law in the Faculty of Law here at HKU, and he is going to talk today about Autonomy, Death, and Dying, a Legal Survey. So we'll finally get a legal perspective from somebody in the Faculty of Law.
I think I better stand. My stomach tends to get in the way. I decided to change my title to this one instead of talking to you about after Carter in Canada. No, I'm not Canadian. Declaration of interest, I'm from the other, even smaller island down south. So today I'll just take you on a whirlwind tour of the common law. I want to first talk about how the law looks at death and how the law defines death. And my talk today is going to be based on the English common law and the common law that operates in Hong Kong. Taxes and death are things which I can guarantee will come to you. If you're exempt from either, then you don't need this talk. I think one basic problem which the law has is that it is really crawling in the dust, very, very far behind the realities of medical technology. But, you know, the law is in pretty good company in this because ethics, religious positions on the definition of death are also basically left stranded by quite extraordinary advances in medicine. So I don't have to ask clinicians here today, how long can you sustain an essentially dead body? How long can you ventilate a corpse? I think the answer would be a pretty long time. Is that person alive? Well, one of the main problems is that so long as you maintain the ventilation, you maintain the corpse, technically there's biological activity. Indeed, you do want this biological activity as a means to, say, ensuring that the organs would be useful for transplants. And that really starts opening a whole can of worms as to the definition of exactly when human life becomes extinct. So the law then has a great deal of difficulty in defining when human life is extinct. In the past, we have generally relied on what I call purely operational criteria, which is to say, you know, we take the convenient stand, which most religious authorities also take, is that cardiopulmonary function is the touchstone of life. It was very easy in days gone by because if you stop heart and lung for a short while, you will be dead, right? So nobody argues about that. But with modern medicine, things are different. And now, with the advent of life support, difficult questions emerges. If the definition of death is not to be predicated on cardiopulmonary function, then what are you going to premise it on? You're going to say, let's move it to the brain instead. Okay? So that's what the Harvard Medical School did in that seminal article back in 1968, in which the phrase brain death is mentioned only once, and that's in the title. Right? They took to using phrases like irreversible coma and things like that. But from my point of view, this is merely pushing, kicking the can down the road. You say that it is not in the heart and lungs, and you say that it is in part of the brain, or at least the whole brain. You're going to have difficulties when you come to questions like, what if technology advances further and you end up with situations like, as has happened, you decide to transplant hearts, especially pediatric hearts, right? Okay? The definition of death in those cases which pediatric heart transplants have occurred in the States was on the basis of cardiopulmonary pulmonary death. So they waited for the heart to stop, and then it stopped. And said, well, this child is dead. We could take the heart out and transplant it to a child who can better use the heart. Now, the heart stopped in the donor. The heart was revived in a recipient. Was there death in the first place? Very signally, in these cases, the transplant team, with the consent of the hospital ethics committee, did not use the brain death criteria. So, in a sense, there's been criticism of operational criteria. We're only looking at biological functions of certain organs. We have not really started to debate about a holistic approach to the definition of death. So here, all around the world, there has been a general move towards statutory definitions of death. In a sense, it makes things more comfortable for the medical community, where the law says, well, the definition of death is blah or blah, right? Hong Kong doesn't have a legislative definition of death. In this, it has decided to follow the UK in leaving into the common law. And to some extent to executive direction, as you can see in the form of the HA Guidelines on Diagnosis of Brain Death 2003. Now, the problem is that in leaving it to the common law and to executive direction, you run the risk of not there being clarity. And if you say, leave it to the common law, the real result is actually to leave it to the medical profession, because that's exactly what the English courts do. Right? The English courts' definition of death is basically whatever the medical profession thinks is actually death. So this approach lacks legal certainty. It does have the advantage of flexibility. And one problem with this approach is that it leaves, actually, medical professions out, exposed on the limb. You might think that it is a very good idea for you to decide as a medical professional when a person dies. From the legal viewpoint, right, it may be full of holes, because if you get the judgment wrong, then you're in trouble, right? So it doesn't offer you the kind of protection which a statutory set of definitions might have. And ultimately, the legality of acts can only be determined ex post facto. No court decides in advance what is right or what is wrong. You do it first, and then they'll tell you. Okay? So, ultimately, I think perhaps we need to think about what Hong Kong as a society wishes to define as the bright line between life and death. Let me move to a different topic, which is an extension of the first. Here, I'm no longer dealing with people who are indisputably dead from most people's point of view. I'm talking about the living, but perhaps the living undead. People who are very terminally ill, people who are in a state of PVS, right? People who are in the last days or weeks of their life, mostly unconscious. In this kind of situation, what is the law relating to decisions for the ending of life in such situations? There's been no significant Hong Kong cases on this, so the English common law applies here under Article 8 of the Basic Law. In this, however, English law is proving not to be a comfort to you, because the UK courts have not been consistent. They have flip-flopped, and in my opinion, very badly, right? Between a series of decisions in the 1990s, which were, to my mind, very liberal, enlightened, to a period in the early 2000s where they were not so liberal. But now the pendulum may be swinging back again, as some of you would know, having attended the seminar we had last month. The UK Supreme Court has, in the decision of Montgomery and the Nukshire Health Board, demolished one of the 3 limbs of the famous Bolam rule. So there may be signs that, in fact, it will move back to a more liberal stance. This is a question which, this is an issue, this is a point which I would like you to understand. Ultimately, even in decisions of this kind, from the legal point of view, it is not the medical profession that makes the final decision. You make the final medical decision as to its rightness or wrongness, whether it is permitted or not permitted in the law, is a judgment for the courts to make. So this point is amply clear. The courts are the final arbiters of what is lawful and what is not, and this is made clear in the case of Airedale and Bland, which is the case which Dr. J referred to a little earlier. So this was a very sad case. This was a young man who slipped into PVS. I think he was about 16 and a half when it happened, and he was the 92nd victim of the Hillsborough Football Stadium disaster in 1989. So in the crush, somebody stood on him long enough to put an end to his most of his brain, but not long enough to kill him outright. So they brought him to hospital, and after 2.5 years, his parents and the hospital and his doctors went to court and said, let him die. Let us remove the nasogastric tube from him. Now, he's not in any danger of dying. People can live for an awful long time in this state if supported. Karen Quinlan survived 12 years after the tubes and ventilation was removed from her. She only died in the end from essentially an infection. So, what did the court do in this case? The application is very simple. Can we take out the tube, sit there, and watch him die? Well, the court ultimately said yes. And they said yes for a somewhat, I would say, distorted avenue of legal reasoning. But for now, I just want you to know that this is the reason why you have that hesitation in the HA guidance for HA clinicians on advanced directives in adults. I quote here, for patients in PVS or state of irreversible coma, consider whether an application to the court is required. Such a consideration is necessary until case law is established by a court ruling in Hong Kong SAR. I think that is a wise statement to make. Okay? So, in Mr. Bland's case, he was, in fact, allowed to die. They took out the tubes from him. I'll let you have the reason later. Ray J was a different kind of case. What do you do with very severely premature neonates? This child is born 27 weeks, right, gestation. His neurological system has not really had a chance to fully develop, so he is developed enough to feel constant pain and distress. No chance of ever having any kind of relational consciousness. So he goes through crises. Should this child be also allowed to die, basically through abandonment? The next time he goes into a crisis, we leave him on his cot, we watch him die. Are you allowed to do that? Notice the doctors and hospitals, in this case, also apply to court. And in this case, too, the court said, yes, let him die. So, what then is the basis of all this? This is the starting point. Autonomy is a wonderful doctrine from a principle point of view, right? It's the kind of principle that people find very difficult to argue with. Don't you want autonomy? Isn't autonomy good? Yeah, it's the same like sanctity of life. You look like a louse if you try to argue against principles like the sanctity of life. But look at what Lord Keith in Adil and Bland has to say. Right? He says the first point to make is that it is unlawful so as to constitute both a tort and a crime of battery to administer medical treatment to an adult who is conscious and of sound mind without his consent. The following statement after the case, which is cited as authority, is perhaps even more significant for today's talk. A patient, the court says, is entitled to refuse treatment even if the treatment may result in death. This is very clear in the English common law. And that refusal of treatment may be on rational or irrational grounds. You might think that this seems a bit odd, but when you think about it, if you're going to give more than mere lip service to the principle of autonomy, you have to allow the patient to make decisions based on other than medical grounds. It could be on emotional grounds, it could be on family grounds, it may be that I'm 91 years old, I've had a wonderful life, I really don't want to prolong my suffering, I want to go. That is completely valid in law. Indeed, it's even valid in law for somebody to say, actually, my feng shui master said last week, it's better to go now, today on the 3rd, than on the 4th. This is valid in the eyes of the law. Autonomy is the kind of principle which is like Mae West. It is good, it is very good when it is good. But when it is bad, it really causes more problems than it may be worth. It is very good for obvious cases where it is really not needed, but it is useless for cases where it is most needed. So, in this respect, what the courts have made clear is that the principle of autonomy means not only that you can decide what treatments you want now, but also what treatments you want or not want in the future. In other words, you can write a statement that says, when I fall unconscious, no tubes, no lines, no hospital, I want to die at home. I don't care if it causes you all this bureaucratic grief, just comply with my wishes. And this is actually quite easy to defend in the law, because if you go against the wishes, right, you essentially commit the tort of trespass and battery. Okay? So this basically is the germ of the idea that people should be allowed to execute advance directives. But as in all things, the devil is always in the details. Because you may say now, in Hong Kong, we are allowed to make advanced medical directives in the common law in any form we like. Yes, that is true. But you also have guidelines that say, perhaps you should have it in XYZ form, right? But you realize also that as medical professionals, guess who has the burden of determining the validity or non-validity, or the enforceability or the non-enforceability of a given advance directive? To which I say to you, good luck. Right? In particular, the problem is one of the trigger. This is a problem which has exercised the minds of legislations around the world. What kind of trigger is or is not legally, morally, socially acceptable? Can you say that when I go into a state of PVS, take out everything? Is PVS itself an acceptable trigger? Or must you be literally dying? Okay. So for this reason, many countries, many advanced jurisdictions have had statutory regimes. The first of this was the California Natural Death Act, and it subsequently spread throughout the rest of the states. So you have lots of material on advanced medical directives in Hong Kong. Dr. Che has outlined some of them to you. I give you some sources to look at here. The long and short of it is, there is a lot that has been said, but essentially you follow the UK position and you have no statutory advanced directive legislation. So what situation are you in? You're living in the common law. Well, it has one advantage: flexibility. You can write an advanced directive in any form that you like. Sounds wonderful. But it has a lot of disadvantages. It does not extend to proxy directives or what in some jurisdictions would be called durable powers of attorney. In lay terms, let my husband, my wife, my son or daughter decide for me when the time comes. The common law does not permit this because you cannot delegate some kinds of discretion which are too fundamental to delegate away to others. So this is echoed, as Dr. Che has pointed out to you, in the guidance for HA clinicians on advanced directive in adults in Hong Kong. To my mind, this runs really counter to reality and social constructs, especially in East Asian societies. How would you like to die? Do you think it's normal? Do you think it's acceptable? Do you think it's desirable for your husband or wife to make the decision for you when you are no longer capable of making the decision? Let me put it another way. If you had not left an advance directive behind, who's going to make the decision? Who is the medical team going to approach to say, well, we are near the end of the road. There is option A, B, maybe half of C. Which would you like? To whom is this question addressed? So there is a big hole here if you don't have a statutory framework, right? I also have pointed out, it leaves the burden of interpretation open to the medical profession. It be on your shoulder, on your head, to decide whether you're acting rightly or wrongly in carrying out an advance directive. You don't have a choice about this. You have to make a decision, because if you don't comply with a valid advance medical directive, you're in hot soup as well. Okay? So all sorts of potential liabilities in terms of a legal challenge over the interpretation and certain terms and triggers. The common law does not give you any kind of protection in the event of fraud, duress, undue influence, or conflicts of interest. What if the advance directive has been sort of like come about because of the result of an earnest beneficiary wishing to speed the elderly relative to the grave? And if you say that the family has no say, then let me suggest for you a very easy way for the family to torpedo the whole business of advance directive. I could just pop up at the hospital and say, Father said last night when you were not around, right, as you should have been, that he wanted to revoke his advance directive. You in hot soup. right? So the suggestion was made that you should continue care, intervention, until this was resolved. When do you think it will be resolved? When the person dies. You're still in hot soup. Okay? And this kind of difficulties was in fact the reason why the British Medical Association in the 1990s made a very abrupt about turn. In 1 year, they put forward a statement which said that leave it to the common law, we want to decide. And then they probably got certain advice from the lawyers, and they quickly came back with a statement and said, oh, we strongly support the idea of a statutory regime for advanced medical directive. I think also a statutory regime also provides other kinds of protections. You should have a body with regulatory oversight, someone to look into defining triggers, somebody that looks at the question of clinical audits and so forth. Okay? Now, I now go on to my last part, which is what happens when autonomy no longer is an option. The law is very clear in this. Autonomy only works when you are adult and competent. The problem is that you may be adult at the end of your life, but you're not likely to be competent. And most people don't die, don't lapse into incompetence with an advance directive. I won't ask how many of you have made an advance directive here, but I think very few. Right? You be careful, you might be run over by a truck tomorrow. So what happens in reality in all common law countries is, despite this mantra of autonomy, 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 the reality is that autonomy counts for very little in the vast majority of the cases. So English law, Hong Kong law, doesn't accept the American doctrine of substituted judgment. We cannot call people into court to say in evidence that, oh, so and so would like it. I remember at one party, she said blah, 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 blah. That is not permitted. Okay? And then the House of Lords have said, no, you cannot. What happens instead is, if you don't have an advanced medical directive, when you become incompetent, the controlling principle very abruptly changes, shifts. The ground literally moves from autonomy to best interest. It is no longer the wishes of the patient. It becomes the legal definition, the legal principle of best interest. Now, you have to be very careful here because the English courts have used this phrase, best interest, very loosely. In a whole different set of circumstances, and its definition for some situations should not be used in other situations. So I'm going to talk only about this particular situation. What if people become incompetent and is dying and has not made an advanced directive? The answer is, well, the law here is remarkably pragmatic. Adam Bland says, best interest here means, if you can cure, please do. If you cannot cure, then you need to think about amelioration, you need to think about retarding the progress of the disease. And you should also think of relieving pain, suffering, and distress. Now let's take a situation of somebody like Mr. Bland, who's been lying on his hospital bed with basically fluid in his brain for 2.5 years. Can you cure him? No. Can you retard his deterioration? Not really. Is he suffering pain and distress? Not really. He's in a state of PVS, or at least we think that he's not suffering. Now, that was the reason why the House of Lords said, here, the best interest test has come to an end. You cannot satisfy this best interest test anymore. This is the duty of the physician to the patient, where the objective of the relationship between the physician and the patient is no longer possible. Your duty as a physician lapses. More importantly, your legal relationship with the patient lapses. From that point onwards, where you cannot achieve the legal purpose of your relationship, you as a physician have no more right to touch or intervene with the body of the patient than the bus driver on the number 10 minibus. It is as stark as that. You have to think in terms of asking the fundamental question, when does the responsibility and right of the physician to intervene and interfere comes to an end? This is the answer. That was the basis on which the court in Netherlands said, we order the doctors to withdraw the tube. We give a declaration to say these doctors should not be liable to prosecution, that they are not committing an unlawful act. Now, if you don't go to court, you're not going to get a declaration. Right? So going to court now seems to be a good idea. Right? The other point, however, is that actually, decisions are not made in hospitals on legal grounds. Instead, hospitals around the world think about concepts like medical futility. In the judgment of the medical profession, has the point now come in time when doctors have to say further intervention will not be of any purpose? It is known by a whole host of names in various jurisdictions, but here I think that Hong Kong is admirably advanced among East Asian countries. It has very transparent public guidance in the form of guidelines on life-sustaining treatment for the terminally ill, and you've heard Dr. Che elaborate on this. Well, I'm afraid my home country doesn't. I think it should have. But what is interesting from a legal point of view is, I wonder who makes the decisions as regards medical futility. And is it the final determining factor? Remember what I said at the beginning. You, as a medical professional, can make judgments about medical futility, but the rightness or wrongness of that judgment is actually not within the jurisdiction of the medical professionals making a judgment, nor indeed any arm of the executive, including the hospital authority. You can have standard rules, you can have standard protocols, but they can be challenged before the law. So this was in fact the experience of the General Medical Council in the UK, because they had a really wonderful set of guidelines talking about what doctors should do in cases of medical futility. And they were promptly challenged by one Oliver Leslie Burke in 2000, in the early 2000s. He brought it all the way to the European Court of Human Rights. He failed. His basic contention was that I'm suffering from progressive spinal cerebellar ataxia. One of these days, I'm going to be paralyzed, I can't speak, I will need feeding, blah, blah, blah. And these people are going to look at the guidelines and then pull the plug on me. I don't want that. I want to be fat. Right? He failed. But the upshot of it was that the court essentially caused the GMC to revise its guidelines, which I thought was simple and clear, to what, in my view, now amounts to a complete volume of legalese, right? Putting it politely, of no, not really much use to clinicians at all. All right, I was going to talk to you about right to die, But I think I will leave it for another conference or symposium. Thank you so much.
Just lean and talk into this. Our next speaker, thanks, is Dr. Jansu Jancha she's a lecturer at the Medical Ethics and Humanities Unit. We're going to have a real philosopher now after we had a real lawyer. She received her PhD in philosophy from the NUS, and she did her dissertation on permissibility of kidney markets. Prior to joining HKU, she worked as a project coordinator in research ethics at the Harvard Medical School and a researcher in bioethics and health policy at the Harvard Law School.
Thank you, Mary. So I will be talking about the ethics side of this whole discussion, and I will move further into the death part, actually. I will start with the autonomy's central role in the whole debate, and two major issues in end of life that revolve around the concept of autonomy. So one is that what should be the acceptable end of life demands by autonomous patients, and that gets us to the questions of euthanasia, physician-assisted dying, euthanasia, and how should we ensure that wishes of formerly autonomous patients are respected. That again connects to what Terry was talking about, the patients who might or might not have advanced directives, but I will be looking more into those who have the advanced directives, but later lose their cognitive abilities to, well, I'll get to that. So going back to the concept of autonomy, what we are basically talking about here is the self-determination, and this is grounded in the moral idea that our free will must be respected. And autonomy is within almost all moral theories, tying this back to Joseph Stalk. In principalism, it's one of the main principles, and it became more and more the prominent principle. But the way that principalism is basically a framework that actually is sort of made from taking the most popular parts of the moral theories and putting them together for giving a quicker guidance in medical field mostly. And where the autonomy principle comes from is actually from deontology, where we have the main name would be the Kantian ethics, where the whole point of the moral theory relies on the individual autonomy, individual decision-making, the rationality of humans. In consequentialism, it seems like we are sort of losing the autonomy, but that's not exactly the case when we look closer. One of the most popular and currently quite accepted versions of consequentialism is preference-based. So the idea is to increase the preference satisfaction of everybody in the society. And when we talk about the preference satisfaction, we are basically talking about the autonomous decisions of every individual and satisfying those preferences. So autonomy plays a very important role in consequentialism as well, as we understand it today. In fact, it gets very murky when we go to virtue ethics, the virtue ethics has its appeals because we look at people and their way of behaving, and we hope that if we can have virtuous agents, then we will have less problems in our ethical decision-making. But in action guiding, virtue ethics is very, very unclear. And the role of autonomy in virtue ethics is also very unclear. So when we talk about autonomy, we expect certain threshold conditions to be satisfied for what we call an autonomous decision. One of them is the rationality, and the other one is independence. And independence here is freedom from coercion, voluntary decision-making. And there are two ways of understanding the concept of autonomy. One is the ideal way of understanding it, and the other one is the everyday understanding of it. Terry was talking about the autonomy as the rational or irrational, the decision that you can make rationally or irrationally. I think that sort of goes to there. In everyday life, we know that we are making certain decisions of ours are not completely rational. We know that we have quite a number of biases and the systematic failures in our reasoning. But that does not, we don't call our decisions not autonomous. We don't say that we are not responsible for those decisions. And we also know that in our everyday life, we are not free from all influences, and we are not free from our constraints. That could be the social constraints, the economic constraints. But again, we call our decisions autonomous. So when we, for example, talk about a lot of our decisions, like simple things like voting or deciding to have a child, deciding to get married, deciding to which job to take, we call these decisions autonomous decisions, even though clearly our upbringing, the society's expectations from us, our families may influence us heavily. On the other hand, when we talk about questions that makes us very uncomfortable, we start moving towards a much more idealistic version of autonomy. So when we start talking about, for example, somebody's right to refuse treatment or right to die, we start asking the questions, well, why exactly is he completely rational? That is does he make decisions based on his, quite largely based on his emotions? A question that we ask much less under normal circumstances. And under different medical decisions as well, by the way. If I were to have, I don't know, a cosmetic surgery, that question would come less strongly. Would come, but would come less strongly than a decision to right to refuse treatment. Obviously, there is an irreversibility there that makes us uncomfortable, which makes us question it harder. Also, in terms of the freedom, independence, when we talk about right to refuse treatment or euthanasia, we often ask the question, well, is the person is making this decision because he or she is uncomfortable about burdening the family? Again, a lot of our decisions are based on the value of family. We might take 3 jobs so that we can support our families better, and that is not considered an not autonomous decision, whereas we might not burden our family with our long period of dying process, and that becomes suddenly a question of whether we are making an autonomous decision. Clearly, we are talking about a spectrum here. So there is no such thing as a fully autonomous versus complete, well, in the end of the spectrums, there could be a fully autonomous and fully non-autonomous decisions, but a lot of our decisions fall into the somewhere in the spectrum. And in the beginning of our lives, this is sort of defined by the law that until we are considered adults, our decisions are taken to be at least not legally autonomous, but in the end of life, of course, there is no such distinction, probably for a good reason. And when we talk about autonomy, we always, especially when we talk about this concept in Asia, we always have this question about East versus West, whether we are using the concept of autonomy in the Western sense and imposing it to the Eastern culture. That is often understood as a cultural sensitivity. It is in a positive sense. On the other hand, it could also be a reinforcement of our superficial observations about the cultures and stereotyping them. One example of this is the well-known phenomena, let's say, in Japan, where the Japanese physicians were told to communicate the terminal illness of the patients to the families rather than the patients. And even though that was sort of explained in a family autonomy versus individual autonomy, in this distinction, it was still quite a big deal, and it made the society feel uncomfortable. So clearly, there is saying that individual autonomy does not exist or is very weak in the Asian culture or in Eastern society is an overestimation. So in bioethics, we shifted from the beneficence and the paternalistic system to this autonomy-based system, which shows itself mostly in the informed consent and the problems we encounter within the informed consent. I have been thinking about the issue of informed consent for a while, and I am still not sure if I have ever given a real informed consent in my life. So after we've spoken about this and we've discussed this issue for years and years, it's still very unclear whether we have attained a real informed consent in practice. And in end of life, when we talk about the autonomous decision making, we cannot stop the discussion in palliative care and how we can support the autonomy of patients during their later lives, but we have to also talk about the autonomous decision to die. And that gets us to the euthanasia talk, obviously. Of course, there are limitations to the autonomous demands, and sometimes these are explained in ways of the distinction between freedom from to freedom to. So one is, it seems that it is easier to talk about the freedom from being intervened, freedom from being forced to a treatment, than a freedom to have a treatment. One obvious reason is that the resource allocation. It is easier to satisfy the demands of people who do not want treatments rather than satisfy the demands of everybody who wants all the treatments, which we can see very clearly the struggles around the world to have the universal health care. And another way of making, another distinction between the freedom from, freedom to, is the obligation. Do we have a stronger moral obligation to not to intervene, not to harm, than to help and help to do good? And one way this comes out is the right to refuse treatment and right to die. Obviously, right to refuse treatment requires more of a freedom from, a negative freedom, rather than right to die, which might require a help of a physician. But it's unclear whether we are talking about real differences here, differences that really hold. So right to refuse treatment is, morally at least, widely accepted. Legally, it gets complicated. I'm not going to get into that talk. Withholding life-saving treatment is much more accepted than withdrawing life-sustaining treatment. Again, the issue is largely related of the action of withdrawing rather than withholding, not intervening. Just like the distinction between helping die, which is giving a drug to someone to kill himself, or injecting the drug so that that person dies. In many end-of-life cases, when we talk about refusing treatment, well, in some portion of this at least, we are really talking about letting die. The expected outcome is the patient's death, and the actual intention is the patient's death. So it is not that we are unclear about these cases. So then the question comes, are we really is there a real distinction between letting die and killing? So how much time do I have? Okay. All right, so I'm still going to get into a little bit into this point. So one thought experiment that was from the 70s, and that sort of shaped this discussion between killing and letting die, was from James Rachel's. And I'll just give you the thought experiment that I think it's not it has seen to be shown very well, but how the distinction may not be a real distinction, morally relevant distinction. So assume that you have two people, so Smith and Jones, and there are two scenarios. Both Smith and Jones stand to gain quite a lot of money if their 5-year-old nephew dies. And they both decide that they are going to kill the nephew and get the money. And one day, they both go to, when the nephew is taking a bath, they both go to the bathroom with the intention to kill the nephew. And when Smith goes in, he sees the nephew and drowns the nephew in the bathtub and kills the nephew. When Jones goes into the bathroom, he sees that the nephew slips and hits his head and drowns. He just watches, and watches very happily that he doesn't have to do anything. So the question is there a moral distinction between these two cases? Does anybody actually behave worse than the other one? If there is no moral difference, then it seems like the distinction that we are making between letting die and killing is a very unclear distinction, and maybe it is for different reasons rather than the seeming action or omission distinction. This the reason why Rachel gave this argument was because of the categories of euthanasia. The argument was that if we agree with passive euthanasia, which is withdrawal or withholding of life-sustaining treatment, then we might not have a good reason to argue against active euthanasia. Active euthanasia includes the physician-assisted suicide, so when the physician gives the drug to the patient so that the patient himself can take it, or the physician administers the drug. Both of them are voluntary cases. The involuntary euthanasia is where the terrible name of euthanasia, the terrible fame of euthanasia comes from. It is the killing or letting die against the patient's will, and that's obviously not what we are talking about. And then there's the non-voluntary one, which is when we don't have the explicit consent of the patient. That is when we have the problems like the patients in persistent vegetative state or children. And just a very short list of where these are allowed in the world. So physician-assisted suicide in 5 states of the US right now, and Switzerland, and active euthanasia, which includes physician-assisted suicide, is in Europe, Benelux countries, Colombia, but Colombia is not actually doing it, it just is decriminalized it. And North America, Canada seems to be getting there, that Terry was gonna talk about, but did not. And one thing about this, another thing that's interesting about this is that, of course, the physician-assisted suicide, the distinction between physician-assisted suicide and active euthanasia is extremely unclear as well, whether there's a moral distinction. Basically, what this makes is that if you are unable to take a drug by yourself, you cannot die. And that seems to be a very arbitrary distinction to make. Why do we need to care about euthanasia and sort of, well, when we care about when we should focus our attention, it seems like, to the palliative care options, why should we still care about euthanasia? Well, one thing is that because it's a legitimate option, and it's an option that an autonomous person can ask for, regardless how well our palliative care system is. And the other thing is that the studies show that euthanasia systematically occurs in countries when it's illegal. So Australian studies, for example, showed repeatedly that 20 to 25% of physicians or nurses, and all of these studies are conducted over 300, 400 participants, did take active and direct steps to hasten the death of their patients. And another thing is that we have to sort of start taking responsibility about what the medicine can do. Medicine has developed to the point where it's extending life greatly, but it also developed to the point that it's extending the dying period greatly. And one of the main arguments usually against euthanasia has been focused on the role of medicine and role of physician, and saying that this is not what we do. We are here to heal the patients. But of course, that is a definition that with the technology, with what we are capable of doing, it is unclear why we have to stick to that definition, let alone that that definition might also include euthanasia, because helping end suffering is not very far from a sense of healing. And the obvious question is, can we prevent the abuse? And how can we best prevent the abuse? One question there is, of course, well, maybe regulation is better than no regulation. And another, when we, with the increase of patients who have severe dementia and Alzheimer's, another problem that we have to deal with is this non-voluntary category, which means that the person does not have a autonomous decision-making capacity anymore. And here, that, by the way, could include previous consent or previous proxy, assigning proxy. And one thing is that normally euthanasia conversation revolves around the conditions of terminal illness and unbearable suffering. Of course, when we start talking about severe dementia or Alzheimer's, the wording of terminal illness becomes very unclear. Those patients are, yes, approaching death because of old age, but they are not terminally ill, which is usually understood to be having 6 months more to live. And unbearable suffering, that again usually is understood to be physical suffering, but here again, we are not exactly talking about physical suffering. this question comes also when for example, when Netherlands and Belgium started allowing the psychological illness to be a reason for asking for euthanasia as well. And in advanced directives, when the patient, when we have the option of identifying when we want into our illness, when we want the treatment to be stopped, or when we want a physician to help us dying, the question gets very complicated. What we have is that a former decision by a formerly autonomous patient for saying that at this point of my illness, please kill me or let me die. But when the patient gets to that point, he doesn't remember that decision anymore. And in his everyday life, he might not want to die anymore. And he might actually fear from dying. And obvious question is that whose decision should we respect at that point? Is it the former person still holds autonomy over the sort of this non-autonomous being? Or should we now say, well, too bad, the former person does not exist anymore? If we say that, of course, as people who are autonomous right now, we have to live with the fact that we don't have control of our non-autonomous lives. And the first idea that autonomy, the autonomous person's decision should hold, is supported by Dworkin, whereas different solutions suggested by Steinbock, the idea of sliding scale, where we have to sort of find the point where the current person, the person who is suffering from severe dementia, really stops losing interest in life, and only then we can honor the former decision. And an interesting argument that comes about the dementia and euthanasia is from Warnock, that's from Britain, is, well, maybe that we have she argues, maybe we have a duty to consider euthanasia when we have severe dementia or Alzheimer's, because we are basically, at that time, we are using the resources of the society and allowing other people not to have that option, meaning allowing other people to die, because we are using quite a lot of the resources. And she thinks that that's a perfectly good reason for asking for euthanasia, making a decision beforehand for euthanasia when we have severe dementia. So as a concern for society, she says, not suffering, no terminal illness, but just concern for society is also a good enough reason. So basically, this is my summary slide. Ethics have been, philosophers have considered to be disagreeing and never having a common point and never really getting forward. But autonomy is something that we finally agreed that it plays a very central role. And, but the issues that are too close to death sparks controversy, and it seems very costly to make major changes. But when we look at how euthanasia discussion have been going and rapidly growing around the world, California recently voted, Massachusetts recently voted, and Canada recently made a decision on this. It is a conversation that is rapidly growing. And we realize that it is becoming too costly to keep the current situation, too costly in the sense not only financial but mentally as well, too burdensome to keep the current situation. And the ethics role, just again to sort of get back to Joseph's presentation, the ethics role in all of this discussion is basically a lot of our policies, public health policies, do argue that certain things are allowed or should not be allowed because they are immoral, because there is a moral reason to keep it in a certain way. And that requires a discussion from the ethics part to say, well, is it really immoral to allow euthanasia, for example? And if it is not the immorality, if it is only the practical concerns, then we should focus on that and not worry about the ethics of it any longer in that sense. And of course, helping healthcare professionals to make hard decisions, especially when they face brand new situations. And that is not only to mean that we want to have doctors, physicians with good intentions, but we want to have a certain ethical guidance to help them make the decisions. That's all. Thank you.
Okay, we have just a few minutes for questions, so it's fortunate that we're having lunch next, so we can have questions over lunch as well for our speakers. But we do have a couple minutes, so Dr. Kwok, do you want to go first?
And that is the reason why we have so much tube feeding and partly why we have so much physical restraint in Hong Kong. And after listening to Terry and Candice, this is a very complicated issue. And it's no wonder that we resort to tube feeding and restraint in real life, because these two actions are much easier than to deliberate on all these ethical and moral and legal issues. And also, all this would take time. And if it involves legal action, that involves a lot of time. Perhaps I'll discuss this scenario with sort of Terry and Candice. So if somebody has terminal phase of advanced dementia, cannot eat properly or refuse to eat almost completely, okay? But that person is not, well, it's debatable whether the person is terminal or not. Some doctors might say, if somebody is so demented, this person is terminal. But when you look at that person, his nutritional status might be all right, and you know that when you tube feed this person, his nutritional can only improve. So it's quite likely this person will survive for more than 6 months. So strictly speaking, this person is not terminal. And also strictly speaking, this person is not in a vegetative state. So my question is it a legal situation here? Okay, as Terry suggested. But even if it comes to the court, how does the court decide? Okay. And then when real life in Hong Kong, we do most of the time, 99% of the time, we put in the tube. And then after putting in the tube, about 50% of the time, they will try to keep pulling it out, keep pulling. In fact, when I visited a nursing home in Hong Kong, that person has been doing it for a couple of years, all the time. She's juggling, and despite all the limbs of restraint, she kept moving around, trying to get rid of a tube. So even for a normal person, so looking at this scenario, you know that this person doesn't want the tube. Okay, it's very clear for whatever reason. Okay, so from the law point of view, would you respect this bodily response? This person is mentally incapable because she's demented, but this bodily expression of refusal, is that not good enough as a kind of refusal from the legal point of view? Okay.
You're the one he's asking.
Well, the easy answer is, I don't know, because your law is not clear, right? And I think there is some point to not treating the law as a monster. And if you say that you are worried about feeding someone manually and insisting on the tube because you're afraid the person will choke and the family will sue you, or that you're worried about safety if you don't restrain the person, I think if the person is like competent, then you have to think in terms of, does that person have sufficient autonomy and right to make decisions as to risk and safety? But in your situation, I can really offer you no comfort. And this is precisely the kind of thing I think which the law needs to explore. The law can only explore that if it has sufficient social consensus to move on. This is exactly the same situation where the law cannot move on the definition of death because there is no underlying social consensus. You do not want the law to be making decisions in a situation where there is no professional and social consensus. So I don't know. It is a very difficult position. You're between a rock and a very hard place. I can only say that the law generally has a lot of sympathy for professionals acting in good faith in a human manner for sound human objectives. So beyond that, I don't know what the view of the law would be.
I'll also respond quickly. I think one thing is that when you talk about the bodily response being a sort of like a decision, it doesn't really work, because when we talk about a decision, we want the person to understand the consequences, and it's unclear whether that person has any understanding of the consequences. And the other thing is that I think the main problem here is that we have no idea what that person wants, and that seems to be due to the fact that we are so used to the former type of medicine that death occurs sort of easily, that we still feel it's easy to not make decisions about our later what happens to us later in the life. And the conversation only happens too late or under very stressful times. We don't really know what to expect. And once, if we knew, we could sort of say, well, feed me or don't feed me, allow this or don't allow this.
Okay, Husoi from CHK Biocenters. I went to the clinical ethics conference last month in New York. There was really interesting discussions about the end of life. And there are two points. One discussion, highly debatable, is whether the four medical principles are useful in other contexts outside of America. It's basically, all the four medical principles are developed by the American philosophers. So there are some highly kind of strongly against the view that we shouldn't really stick to the four medical principle in terms of in practice, because it doesn't give really any good guideline in terms of the specification or balancing. We don't know how specific they are, how balanced between autonomy, beneficence, etc. So, I mean, there's one thing we should consider, that the medical principle doesn't give a good answer to the practice. The other part about the issues that I'm not sure about whether the ethical issues of the non-autonomous persons about the autonomy, because I mean we could have some good discussions in terms of the conceptual discussion about whether that person before the dementia or the same person of the current person dementia. But I guess the real question here in end-of-life care is about whether and how much we should give the treatment that are considered to be non-beneficial. I guess the questions about okay, we know there are some issues about the autonomy, etc. But I guess the real question in the practice is that how much we should give the non-beneficial treatment to the patient. That's what I guess the real question that comes out, the medical futility and the non-beneficial treatment these days end of life care.
Sorry. Okay. Well, with the four principles, I completely agree with that. I think the four principles have been understood terribly wrongly, which messes up quite a lot of the thinking, because what the four principles are meant to, well, should be used as a guidance for starting how to think about it. They, as I said, they basically cherry pick the best parts of a lot of theories, and the reason why those theories give different weight to these principles is because they clash. So four principles does not get you to an answer. It only makes you start thinking about it. And about the beneficial treatment, I think before that though, if the person wants to terminate or refuse treatment quite early in his dementia, much earlier than it could be called non-beneficial, I think then the question arises.
I would offer a more cynical, skeptical view. Beecham and Childress's four principles are very influential. Some people refer to that as the Georgetown mantra. I'm not entirely persuaded of its application and its appropriateness in many clinical situations. I only have to ask you the question, who gets to decide on the application of these principles? What is the underlying assumption? Well, the answer is, of course, the physicians. The Georgetown Mantra finds no resonance whatsoever in the English common law. So I think you need to treat it with a lot of caution as a principle to apply in clinical practice, and you should be very aware of the possibility of using it as justification for doing things which the law might not support.
I think you would probably all like to have lunch. So why don't we continue this wonderful discussion over food, which I believe is being served on the 3rd floor? Thanks, everyone. 3rd floor. Yes.
Thank you.